and I want to talk with you about knee arthroplasty and preoperative preparations. So this is my conflict of interest. So the facts and numbers about knee arthroplasty in Germany. Currently, we are performing about 150,000 arthroplasties per year in the whole country. And the numbers are pretty stable over the last years. So we have reached some sort of saturation here, but the revision numbers are still going up. Currently, it's around 20,000 revisions per year. And we have many certified centers for arthroplasty. We have a very strict quality management system employed. And so there are around 600 certified centers. And we can claim that we are pretty experienced with arthroplasty, and we are here in rank number 5 worldwide in means of arthroplasties per capita. It's about 222 arthroplasties per 100,000 inhabitants. So we are performing quite a few of them. And still up to 20% of the patients that receive a primary arthroplasty are not fully satisfied with the procedure. So there's still room for improvement. So, of course, we work with a preoperative checklist, and there's many basic things on here that you need to have before you can start with a surgery. And I want to go into some of these and shed some light into this. So I always tell my residents that surgery is a little bit like a marriage. So you shouldn't make any haste, and you shouldn't do it on a first date and not on a first appointment. And you should pick your significant other with great care, because most likely you will spend a lot of time with each other, and most likely your significant other, your patient, will find you for the rest of your life if he's not happy with you. You should make very thorough preparations to have a successful procedure. And honesty always prevails in marriage as in surgery. So always set your expectations right, and always tell the other side what he or she has to expect from you. So in means of indication, in Germany, there's quite strict regulation and things you need to have before you can go into surgery with the patient. And you need to document these things in your patient file. The patient should be in pain for at least 3 to 6 months and be in continuous need of analgesics. You should have, of course, signs of osteoarthritis in the X-rays. You should suggest to the patient a conservative treatment approach first, and this should have failed before you go into surgery. And there needs to be significant loss in quality of life. And I tend to say that the patient should make the suggestion to go into surgery and not the surgeon, so you know that he is or she is ready for this. Also, you need to see that there are no strict contraindications to go on with your procedure. I'm very firm about preoperative planning, because there is so much variation in needs around the patient, and there are so many different cases that you can go. And even though I do perform a lot of surgeries every year, I still plan every single case, and I plan them all by myself. So there are simple arthroplasties where you can just put in the implant in your planning, and you see everything works out. And there's more complex cases where you have modular implants and you need to put them together in the right way. And my plannings are pretty precise. Normally I'm plus minus 1 size. And I benchmark myself on these all the times. And I tell my residents that they are not allowed to go into the OR without a proper planning that they did themselves. And you can anticipate a lot of problems that you will have in the OR if you do the planning before, and you save a lot of operation time if you do this properly. You do need to know your implants. You need to know the contraindications. Many manufacturers, for example, rule out allergies against metallic components. Many manufacturers rule out obesity, and you need to read your instructions to know what your implant has on contraindications. At least in Germany, you need to be instructed on the implant and on the instruments, and you need to have that documented. I'm not sure on the international affairs, but it's always a good idea to know all your tools well. And you need to decide in advance if you need a product specialist present in the OR or not, and if you need to have any special forms signed for that. Also, you should have all your implants available. We tend to have all implants available in double, so in case something goes wrong, we still have a spare in the room. And also you should have a plan B. So you need to know if your collateral ligaments are intact or not. You need to know if you have bony defects or not. And you should always have the next size implant in the hospital in case you need to upgrade from resurfacing to semi-constrained or from semi-constrained to total hinge or rotating hinge. So you should have a good portfolio of implants in your hospital ready. So let's take another look at your significant other, your patient. There has been many studies published on risk factors that the patient brings in. And so there is yellow flag and red flag criteria. You should have a look at the blood cell counts. You should have a look at the hemoglobin level. And you should have a look at the diabetic markers like the hemoglobin A1C. You should also see if he's screened from the dental department, if he has any loose or disrupted teeth. You should see if he's a tobacco user or not, if there are any wounds on the lower extremity, and you should judge very carefully if these patients are really suitable for surgery in your hands or not. We do screening for Staph aureus on all our patients to reduce the risk of them bringing in resistant germs into the hospital. And there's been evidence that you should also screen for sensible Staph aureus, not only resistant, but the screening is quite expensive. You need to bring the patient in a week or so before the surgery into the hospital, and you need to take the swabs. And it might be more cost efficient just to wash all your patients and treat all your patients and just don't screen them all. So there is different body washing solutions you can use. There's nasal ointment you can use to decolonize Staph aureus from the nose. And there's significant evidence that you can reduce your surgical site infections by decolonizing your patients from Staph aureus. So in means of diabetes, there's a lot of different literature being published on this, and to be honest, there's no real clear evidence. So this was a big review controlling patients with and without diabetes, and with well-controlled diabetes with a HbA1c below 7 and above 7. And if you look at the very right side of the slide where the p-values between the two groups are given, you see there's almost no significant differences between these groups. A few things like postoperative stiffness tend to be significant, but the overall complication is not really that much higher in patients that have a badly controlled diabetes. But what I find from my own patients is that the diabetic markers are also surrogate markers for poor compliance. Those patients that show up with poorly controlled diabetes also tend to not follow doctor's orders very well. And so you can take this as a surrogate parameter to see if your patient will follow your instructions or not. And also patients with the diabetes tend to have higher comorbidities, and I will go into that in a few slides again. Many hospitals try to employ urinary screening on all their patients, and there's also good meta-analysis data on that. So if you have patients with a symptomatic bacteremia, you should treat them before, because the odds ratio of complications is significantly higher. But if they are asymptomatic and only the test is positive, it doesn't really matter. You don't need to treat them, or it makes no difference if you treat them or not. And so we do not recommend screening of all the patients. We only do tests if they have symptomatic bacteremia and have pain while urinating, and then we do testing, and then we treat them and delay the surgery for a week or two. So on obesity, there's also a lot of data being published. This one is a big meta-analysis of 37 studies. And you can see the relative risk for any kind of revision raises with the BMI of the patient up to almost 5-fold with an extremely obese patient with a BMI more than 50. And the revision for septic reasons also raises a lot with the increasing BMI. You see also 5-fold for BMI greater than 50. So the problem with the obesity is, can it even be optimized or not? So you can decide not to operate these patients and send them away. And but the problem is you cannot really help them this way. So we are trying to optimize these patients together with a bariatric surgeon and put them in a program where they can lose weight in a very controlled and supported manner. But what we also see from the study, that even if they lose weight, their relative risk for complications doesn't really decrease, at least not within the first 1 or 2 years, because their metabolic system is still in a diseased kind of way, that it's still programmed on the obesity. So you probably need to wait much longer after weight loss before you do the surgery. But in most cases, this is not really practical, because the patients have a loss of quality of life and they suffer and do quite a bit. So in the end, this is up to the surgeon if he takes the risk or not. And again, you need to be honest with your patients. I tell all my patients that they have an extremely elevated risk in the surgery, and we try to argue this together if we are willing to take it or not. So in the last years, the concept of prehabilitation has been, there's been some raising evidence that this might be a good idea. So you actually start physical therapy and patient education on how to move and how to walk and how to train before you do the surgery. And actually you get better results post-operatively, especially in the early post-operative phase. You have better function and you have less pain if you do a prehabilitation program. Also, the evidence suggests that these advantages are not that much present after 1 or 2 years after the surgery, but you get the patient a head start. So he comes out of surgery better than without. And especially if you're looking at length of stay and you try to optimize the time the patient stays in the hospital, then this can really help. We do patient blood management with all our patients. And if we look at the German collective of total knee arthroplasty, I'm sorry, this slide is in German, I couldn't translate the images. We have an average of 70-year-old patient, and you see about 15% of these patients come into the hospital already with a preoperative anemia. And so we try to optimize these patients. We can use erythropoietin or Ferinject, this is injectable iron, and we can reduce the length of stay, and we can reduce the rate of transfusion quite a bit. And we also use routinely tranexamic acid in our patients when there is no contraindication, and this reduces the blood loss severely in the operating room. So this is really something you should take into account, especially if you're dealing with older patients. So we have a look at the medication that the patient brings before surgery. You should avoid therapeutic anticoagulants if possible. Aspirin may continue. There's no evidence that you have higher risk of bleeding, and the cardiac risk factors always outweigh the possible optimization here. With the oral anticoagulants, we are not bridging them preoperatively. If possible, we just pause them 48 hours before, and after the surgery, we start the patients on low-weight heparin, and we try to go back to the NOACs as soon as the wound is clean and dry. The post-operative NSAIDs have been used for years, for decades mainly, but there's rising evidence that these medication can delay the bony healing. So especially if you're working with uncemented implants, you may want to think about restricting NSAIDs to the necessary amount. And also you need to look into the renal insufficiency, especially in older patients. Many of them rise with the creatinine if you use the NSAIDs too much. We only use single-shot antibiotics in the operating room. You need to be aware of your dosing intervals. So especially if you use antibiotics like vancomycin, they should be administered at least 1 hour before you cut into the patient, because they have a long time before they are actually in the blood flow. At least in Germany, there's a rising concern with the legal matters before you do the surgery. You need to encourage a second opinion in the patient, and I think this also comes into the honesty lasts longer. So if the patient asks, where else can I go, you should recommend a good colleague, so he gets another colleague to tell him what to do. You do need to try the conservative treatment and see if it's doing any good, and you should be very honest about expectations, risk, limitations, and success rates. I also tell my patients that there's a 15 to 20% ratio of patients not fully satisfied, and that we so we have the expectations right. I always tell them that it's possible to do intraoperative modifications as needed, especially in the choice of the implant. If the ligaments are not as stable as expected, that I can upgrade the implant. We have standardized and legally approved informed consent forms. So we're on the safe side of that, and we always give a copy of that to the patient for liability reason. Also, a rising concern is the off-label use of the implants. I told you before, allergies and obesity are a very common contraindication, and often you don't have any alternative, so you won't find an implant that is in label for certain groups of patients. So you can still use them, but you need to tell the patient that this is off-label use, and you should make a note about that in your patient file so you don't get any legal problems afterwards. So we are trying to calculate complications from our patients, and this is from one of our own studies with a large group of knee arthroplasty patients, where we looked at the comorbidity score and different lab values, and we saw that especially the Charlson Comorbidity Index correlates with unexpected adverse events and also with the admission to intensive care unit after the surgery, and also the preoperative hemoglobin level correlates with that. The lower it is, the more likely you are to have adverse events. C-reactive protein also, the higher it is, the more likely you have adverse events. So you can, to some degree, you can calculate, and you can try to put your resources into certain cases where you are most likely to need them. So from my take-home message, the primary knee arthroplasty is an elective procedure, and it can be optimized in some ways. You should look at your patient-related risk factors, and you need to see if you can minimize them. Always plan your implants, even if you consider yourself a very experienced surgeon. Always make a plan before you go into the OR, and have a plan B ready in case your primary plan is not working. And always be honest with your patients, communicate well with them, tell them what to expect, set the right expectations, so everybody will be happy after the surgery. And thank you very much.